I'm Tom Fitch. I'm a physician. I'm part of ZELO, or Arizona End of Life Options. It's a group of volunteers. I think most of you are probably aware of that, whose primary goal is to see if we can get a medical aid in dying law passed in Arizona sometime in the near future. I have been a resident, my wife and I, we have three daughters, none who live in Arizona anymore, but we came to Arizona in 1988. I'm a hematologist and oncologist. I've taken care of people with advanced cancer and cancers for well over 30 years, although I retired 2 years ago. Kind of the latter half of my career, I did more and more. I'm also a boarded hospice and palliative medicine physician, and cared for people, again, with advanced serious illness, and a lot of people near end of life and at the end of life. I worked for Mayo all those years. Again, I retired almost exactly 2 years ago. I've been very privileged to be a part of this movement. Was asked to participate, and primarily to try to help with education. That COVID's put a little curveball into that, but these webinars, I think, are good events, and so that's what we're going to do today. We're going to talk about kind of end-of-life options, and I'm going to start by talking why I think that's so important for people with advanced illness to know that, and to do some of the things they should be aware of and need to do as we get older and illness becomes a part of our lives, and we try to live with that. And as illnesses advance, to be very frank, the medical community at times is not very helpful with that, and we'll talk about that. And then obviously we're going to talk about medical aid in dying, and review that, review some to some extent, not in great detail, but some detail about the proposed Arizona law, a little bit of the experience in other states, and then stop, and be a lot of people here, but I certainly will be available. We'll try to help with questions and concerns that people might have. So as I mentioned, we're going to review kind of the title of this in the webinar is the 6 options, but the options that are important for people to be aware of, those with serious advanced illness, as their illness advances. We'll talk about medical aid in dying, and I'm going to review the experience in Oregon, a paper that was published not too long ago, reviewing kind of Oregon's 20-year experience. It's over that now. And, you know, the combined experience now in the United States is well over 50 years. We'll review a little bit of some of the concerns that frequently pop up, and then talk about Arizona end-of-life option resources that are available to everybody. So if you ask people, you know, how they want to die, or where they want to be at the end of their lives, the overwhelming majority of people, over 80% of people, will report that they'd like to die at home. It's improved in the last several years, but still well over 50% of people die in institutions, either in hospitals or hospice units or long-term care facilities, and not what they would identify as their home. It used to be higher than that, so things have improved. But many people still don't die where they wish they would. Obviously, many people, most people want their pain and suffering managed. That's one of their primary goals, that their symptoms are managed and managed well, such that they're comfortable. One of my favorite quotes is from Woody Allen, who said, "I'm not afraid to die. I just don't want to be there when it happens." I think that's true for many people. I think many people, as they deal with their illness, they're not fearful of their death, but the process of dying is fearful to them, and they've heard and seen people whose death were not very comfortable. Obviously, people want their religious and spiritual needs met. Often that's not done well within the medical community. and they want their values, wishes, and well-being supported. And again, within the medical community, sometimes those are not pursued. Physicians don't ask people what their wishes are. Patients and their families sometimes are reluctant to express those wishes, and then they get kind of caught up in, I call the medical train that's running down the tracks, and the individual patient's wishes are left behind. And most people don't want to be a burden to their families and friends. They want a system that's going to care for them and not overly burden their families. I like this cartoon. It's an elephant visiting his psychiatrist and saying, sometimes even if I stand in the middle of the room, no one acknowledges me. And I think that's a good metaphor for kind of death in the middle of the room. As people's illnesses advance and their dying becomes part of what appears to be more obvious, still it's not discussed. As I was a hematologist and oncologist, one of the things that drew me towards palliative medicine is I came to realize that a lot of my colleagues were very uncomfortable with these conversations. And it's not that they don't care for their patients, but there is no, I think it's improving some, but still not to the degree it should be, is that physicians are not trained in communication. They're not trained about complex communications that occur towards the end of life. And many physicians just don't know how to carry out those conversations. So to be honest, they don't. And patients and families are often reluctant. They are thinking about their death. They know they have a serious illness, a terminal illness, but that conversation never arises. Unfortunately, where that leads, the term that's often used in medical literature is medicalization of dying. And I call it, let's try this medicine, that the substitute for physicians, instead of talking about a progressive illness, the lack of benefit of additional treatment, those are difficult conversations. And again, many physicians just providers are not very comfortable with those conversations. And they're long, complex conversations. Often people need to have those done and several times. But the physician, lack of time, lack of skill, so he and she default to I call it, let's try this medicine. It's a lot easier to talk about the next drug that we could try, or the next procedure or surgery. Those are easier conversations, and so that becomes the default. Alan Verhey, in a book that's titled The Christian Art of Dying, he called it the tyranny of survival. In the endless efforts to defy death, the opposite occurs. Death is allowed in early victory, because what happens, and what people see so often, is that relentless disease-directed treatments lead to as much and often even more suffering than the disease itself would have without treatments being piled upon one another. And commonly, treatments can actually shorten survival. But patients, again, don't hear about that. And as I mentioned, people get caught up into this medical train that's running down the tracks, and more treatments, hospitalizations, and end up with surgeries and ICUs. And I could quote you lots and lots of statistics, but one that's always struck me is still today, nearly 1 in 5 people in this country die in intensive care units. This cartoon always struck me too. You've got 6 months, but with aggressive treatment, we can help make that seem much longer. This was a patient along similar lines. I'm doing everything I can to extend my life, but no one has the right to prolong my death. Again, when you start to have those kinds of conversations, it does have to include a conversation to say that there comes a point where more and more treatment becomes more detrimental than helpful, and that more treatment can actually shorten somebody's life. And often those conversations are not held. So end-of-life care, I think, needs to be humanized. in our current medical experience. It has to be a human experience, and cure cannot really be our singular goal of medicine, because it's really not a question of if we will die. People with advanced illness, all of us at some point will die, obviously, but it really becomes a question of how we want to die. And those conversations just have to be had. And as healers, our providers, physicians must determine and pursue a patient's wishes, goals, and well-being and values. I like to call it well-being. What's important to a person? What do people value that make their life worthwhile to them? And you have to identify that, because again, treatments can begin to really interfere with patients' goals and values. What do they want to accomplish? If their life is clearly limited, what are their goals and wishes for the near future? And their treatments need to be designed to meet those goals. So how do we avoid that tyranny of survival? We need to do better at improving medical providers' communication skills. Again, they're not taught that. There are significantly increasing efforts. I think there's a realization, if you look at all the studies that have looked at end-of-life care and the shortcomings of end-of-life care in medicine, there is one common factor that's pointed out in all of them, and that's communication and our ability to effectively and empathetically talk to patients and their families and give them what is well-informed consent about the true benefits and limitations and risks of additional treatment, and the idea that sometimes, again, additional treatment, disease-directed treatment, is not in their best interest. It's not about giving up. It's not about, there's always care that you can provide people. But sometimes stopping disease-directed care is best for people. And it has to be a shared decision that's made with the patient and their family. And advanced care planning really has to be a part of that. Medical power of attorney and filling out a living will. And I always called it current care planning, because it's really hard for somebody with an illness, even a serious, again, I called advanced care planning current care planning, because even people with a serious illness, it's hard to think in the future and then to identify the kind of care that you might want, or whether you'd want advanced life support and those sorts of things. Now, some people know very clearly what they want or don't want, but many don't. So I always told people, just pretend today that you were faced with the need for advanced supportive care, and whether you would want that or not. Because again, the important part of advanced care planning is it's something that should be looked at and reviewed continually, particularly as an illness progresses. And you can always and should change that as you go. And I told people to write a letter to me about what was important to them. And we would include that in their advanced care planning, what their wishes and goals and what they valued. And we'd look at that letter and try to decide if additional treatment fit into those wishes and goals for patients. And then again, we're going to focus a little bit on expertise in end-of-life care, because many people are not aware of the end-of-life care options that are available for them as illness progresses. So expertise in the care of the dying is very, very important, and certainly not all physicians have these expertise. And this is a good time to shout out the importance, I think, of sometimes getting palliative care physicians involved, and then at the appropriate time, hospice physicians involved. And many palliative care physicians also are hospice caregivers, but there's a difference between palliative care and hospice care. Palliative care is supportive care during a time when disease-directed care is being provided, but palliative care, I call it that extra layer of support. It's physical care, pain management, symptom management, but palliative care is really good. Palliative care is a team. There are social workers involved, nurses involved, chaplains involved, pharmacists. They provide social, emotional, psychological, all that like whole person kind of care. And again, each of those individuals is trying to support the patients in the best ways that they, their expertise allow them to do that. And again, to identify the patient's, obviously their symptoms, to alleviate symptoms, but then what are their wishes, goals, and values? And everybody is trying to care for the person in the way that they want to be cared for based on their goals and wishes. Sometimes, in palliative care, the social worker becomes the most important person. Sometimes it's the chaplain that's the most important person in the care of that person. And, it's true in medicine. Medicine, disease-directed care has gotten so complex, certainly within the oncology cancer world, and I think it's true in all the different disease specialties in medicine. The complexity of care is enormous these days, and not one person can't do all of this. So to have a supportive team that's addressing all these other issues is very important. Then again, people can decide about withholding or withdrawing. Now, ethically, withholding and withdrawing is felt to be the same. Somebody, the extreme of somebody being in this world of COVID, being intubated, put on a machine to help them breathe. Sometimes a patient, family will choose, I don't want that, knowing that they probably will not survive without that support. Or they may get be intubated for a period of time, not improving, in fact, declining, and they withdraw that support. And again, ethically, withholding and withdrawing are ethically the same. And there are lots of advanced supportive therapies along, not just intubation, but cardiac resuscitation. In the purely medical world, we even think of hydration and feeding as medical interventions, and that families can choose to stop those, or patients, obviously, or devices, defibrillators and other cardiac devices and such. Again, one of the choices in end-of-life care is to enter hospice. Again, hospice being at that point that in this country that the prognosis is felt to be 6 months or less, and the person chooses to stop disease-directed therapy. Now, it isn't necessarily all. I always talk about, for example, heart failure. If a patient with heart failure and is declining, it looks like their prognosis again is less than 6 months, they may choose to go on hospice, but they can continue. Hospice will support any medication that helps them symptomatically, any medication that makes them feel better. But they are making a choice that perhaps I don't want to be hospitalized, I don't want to be in an ICU anymore. So those advanced directive therapies will not be pursued, but any therapy that helps them feel better, hospice will be supportive of that. There is what is called voluntarily stopping eating and drinking, where a patient has no, again, is considered other options, and one option is for them to stop eating and to stop drinking. People can starve for quite some time, to be honest. But people who really don't drink and are not being supported with intravenous fluids, their life expectancy is 10 to 15 days at most. I would tell you in my experience, it is very hard. I did not have, I had a few, but in my long career, I can count them on one or two hands, the number of people who are really able to do this. It's very difficult, lots of family pressures. It's tough to watch, and there's symptoms with that. So that's not an easy thing. Somebody who's conscious, and there comes a point for all of us, and if a natural death, will stop eating and drinking. But to do that earlier than what is kind of part of the normal death is difficult. There is palliative sedation, which is legal. Palliative sedation is where you actually put somebody to sleep. Now, it's in the setting where they have symptoms which are refractory to all other care. And pain becomes an easy example. I've had patients where I've done this, where we have, had somebody with a cancer, other illnesses, where we've done everything we can to try to control their pain, and we've not been able to. I have a patient, it was a young woman who was in her 30s who had pancreatic cancer. And I cared for her for about a year. Treatments were not very effective, and she had a lot of widespread metastatic disease. And near the end of her life, we just were not able to control her pain. We had her in an inpatient hospice setting for I think a couple of weeks, and her pain was not controlled. She just pleaded for us to do something. Her parents were there, her husband was there, her son, who was 10 years old, was one of the most mature 10-year-olds I'd ever known. But the whole family, she requested palliative sedation. Everybody of her loved ones agreed with that, and we put her asleep, and she died about 12 days later. So the difference in palliative sedation is the purpose of putting somebody to sleep in that setting is the purpose of your intervention is to control uncontrollable symptoms. So one of the options now available in the United States in the District of Columbia that we believe should be one of the end-of-life care options available for us in Arizona is medical aid in dying. So I want to briefly review what is medical aid in dying. It's when a physician, it would be a physician, the law would be physicians only in Arizona. Other states do allow nurse practitioners to participate. But in this state, it would be a physician who would provide a patient who has capacity for medical decision making. They're terminally ill with a prognosis of less than 6 months. They're adult, 18 years old or older. They're given a prescription for a lethal dose of a medication. Upon the patient's verbal and written request, we'll go through some of the requirements to go through this. And the patient has to be able to self-administer the medication, but it is a medication that will end their life if they take it. That's distinct and different from euthanasia, which is basically the same, but the medication is given by a third party, most commonly by a medical provider, a physician or a nurse practitioner, physician assistant. In Canada, where medical aid in dying and euthanasia is allowed, the overwhelming number of patients, 99%, choose euthanasia because there a physician can give the medication intravenously. It's simpler, it's certain, it happens quickly. But that's the distinction. It's all the same, but the physician is giving, again, a third party, is giving the medication to the patient. Medical aid in dying, that cannot be done. Euthanasia is not legal anywhere in the United States. And medical aid in dying, the distinction is the patient has to self-administer the medication, and it's a medication given by mouth. So I was going to quickly go through kind of some of the eligibility requirements, and it is an involved process, and I think necessarily so, that when this is undertaken, it's done in a way that respects the patient and their family, and that everybody's certain that this is the right decision for this person. So the eligibility requirements and all the laws in the United States are really very similar. Most of them are patterned after the initial Oregon law. Oregon was the first state, 1997. And so they're all quite similar. So it has to be, in this country, it has to be an adult, 18 years or older. They have to have a terminal illness and their prognosis, with a prognosis of 6 months or less. And the person has to have the capacity to make their own medical decisions. Capacity is, again, it's complex, but and physicians can assess capacity, but the ability to understand they have a terminal illness, what their prognosis is, the alternatives to medical aid in dying, and again, all those other options that exist for end-of-life care, and to be sure that they understand that there are alternatives available. And they have to be able to retain this information and come back and discuss it again at some delayed time. Again, there's many things that we look at to determine that somebody has the capacity to make their own decisions. This is a bit wordy, but I thought it was important to kind of go through these. So a patient can make a request really to any physician. I put in willing physician because there'll be physicians who do not want to participate, even to the point that they don't want to refer somebody to a physician who is willing to participate. So as we'll discuss in a little bit, I think it's important to know in a state where medical aid in dying is legal, you have to know where your physician stands. But again, so it can be initiated by making a request to a physician. Often, a physician may be, I call them assessors. In Canada, they use that term, that somebody's willing to assess the patient, kind of assess their eligibility, and then refer them to somebody. They may not be willing to actually participate, to give the prescription for the medication. But bottom line is that there have to be two physicians who are assessing and or participating. So if somebody's willing to assess the patient and knows the law and do all the things that are necessary, they then can refer them to somebody, a physician who's participating, i.e. somebody who's willing to write the prescription. So the patient has to make a verbal request to one physician, can then be referred to another, and again, make a second verbal request to both of those physicians, and those physicians have to go through a complete history and physical and assess capacity, that they, that they have a terminal illness, that they believe their prognosis is less than 6 months. And so they go through that whole eligibility and they provide informed consent. They go through and make sure the patient understands the alternatives that are available. There is a need to refer to psychiatry if there's any concern that the patient may not have capacity or that they have depression or some other psychological illness that's impairing their judgment. And the patient has to acquiesce to that referral. If the physicians are concerned and the patient refuses, then the process will not move forward. The patient then must also submit a written request, which they have to sign and date. And then that written request also has to be signed and dated by two witnesses who are not family members and are not entitled to something, like something in the patient's estate, that they're distant from the patient in that regard. And those witnesses must attest to that they believe, as best that they are able, that the patient has the capacity to make this decision and that the patient is acting voluntarily. The physicians are required to do that too, to privately talk to the patient, to be sure there's no coercion that's occurring. The physician must offer the patient an opportunity to rescind specifically, at any time they can offer that, but specifically they must make it and it must be documented in the medical record after the patient's second verbal request. The patient is able to rescind their request at any time. Kind of near the end of this and they decide they don't want to do this. And we'll talk about that a little bit. But the patient is free at any time to rescind their request. In most states require that the patient in the state who's pursuing this, if it were legal in Arizona, they must be a resident of Arizona. Now, in the law that's outlined, it's not very difficult to be a resident. That can include having a Arizona driver's license or some Arizona non-operating license. They can just be registered to vote. They can own or lease property in Arizona. They'd file an Arizona tax return that would qualify them. And then they have one of those vague sentences, or other means of demonstrating residency acceptable to the physician. So again, it's not too difficult to become a resident of Arizona as outlined in this law. There must be 15 days between the first verbal request and the written prescription. Now, built into the Arizona law, and some of the other states have also revamped their laws, that now if you see a patient, one of the things that was happening, that these 15-day laws, 15 days were written into the laws, sometimes you would see a patient, you were pretty certain that they were not going to live 15 days. And they still wanted to pursue this. And so that 15 days in the Arizona law, as it's currently written, as proposed again, that 15-day period can be waived if the two physicians feel the patient may not live 15 days. It's important that the patient must have capacity at the time of the request, and they must have capacity at the time they take the medication. It's important, particularly in the world of dementia, and we'll touch on that just very briefly. So they have to maintain capacity throughout this time period. And as I mentioned, the patient must be able to self-administer the medication. And you could imagine some of the particularly neurodegenerative diseases, patients may lose that ability to actually raise a cup to their mouth or put a medication in their mouth, or lose the ability to swallow. Other provisions that some people often ask about is that wills, contracts, insurance, annuity, those sorts of policies and such are not affected by a person's choice of medical aid in dying. Medical aid in dying is not suicide or assisted suicide. We'll review that in just a sec. And MAID's not a diagnosis. And what I mean by that is that when people go through the process of MAID and the medical aid in dying is completed, physicians don't put medical aid in dying as their diagnosis on their death certificate. For example, if a patient of mine who might go through this and had advanced lung cancer, the diagnosis on their death certificate would be lung cancer, not medical aid in dying. Bottom line for me, MAID is not suicide. Again, it was often termed, and some still do, including the American Medical Association, term it physician-assisted suicide. There are many distinctions, I believe. Patients who pursue MAID, they really don't want to die. That choice, unfortunately, has been taken away from them. They have a terminal illness. They are dying. They are going to die in the near future. So whether they want to die or not, that's no longer a choice for them. They have full capacity to make their own healthcare decisions. That's often not true. And people who, suicide patients often have lost capacity. They have serious advanced, often mental illnesses, severe depression, and truly do not have capacity for medical decision making. People who pursue MAID have been told about their disease. They understand their disease's expected course. They understand their prognosis. Again, none of that's true in the setting of suicide. MAID people who pursue MAID have support of their families. This is most often pursued together. Their deaths are meaningful and peaceful and carefully planned. Their deaths occur with family and friends surrounding them. Again, none of that is true for people with suicide. And for the family, the grieving process, because this has all been thoughtfully planned, the grieving process is normal. Guilt on the part of the families is very, very rare. Again, just the opposite in people who pursue suicide. So none of those things are true for those who commit suicide. And again, I just think that there's no equivalent here. So this is through June of 1997, so almost 20 years of experience. The most common reason, may surprise, is really kind of loss of being what I term well-being, being the person you've always been. You've lost autonomy, you're no longer able to do the things you've always done, your quality of life suffers, and loss of dignity. Those are by far the most overwhelming reasons for pursuing medical aid in dying. Most people, when you ask, will say pain, but only about a quarter of patients pursue medical aid in dying for pain. Now, again, a lot of these this isn't just the sole reason. Many of the people will have multiple reasons why they pursue. Sometimes cost of therapy is included in that. Sadly, that their treatments have become so expensive that they no longer want to pursue that. Now, again, that's not, and that wouldn't be qualify somebody as the sole reason, but sometimes people, that's part of the reason they're pursuing medical aid in dying. If you look at median times that when they take the medication, they go to sleep quite quickly. The median time is 4 minutes. They die generally within a half an hour. There have been patients where it's taken quite some time, as you can see. The efficacy is well over 99%, but there have been a few people, again, this is over a 20-year period, that 7 people actually took the medication, went to sleep, and then woke up. So it turned into palliative sedation. The medication that was initially used was a barbiturate, most commonly a drug called secobarbital or Seconal. Unfortunately, in our capitalistic society, it became so expensive that it's no longer being used, and they've come up with a mixture of medications. Diazepam is Valium, digoxin is a heart medication, morphine is an opioid, as you know, and either amitriptyline, which is an antidepressant that has significant cardiac side effects, or propranolol, which is a cardiac medication. So it's a mixture of those that are given to the patients. Generally well tolerated. Complications from this are pretty infrequent, and most commonly it's vomiting. So kind of part of the process now is that patients are given anti-nausea medications an hour, hour and a half prior to taking their lethal dose of medications. In the United States, it's not required that a provider be present. In Canada, the physician has to be present. That's part of it, but even if it's medical aid in dying, where the patient takes the medication themselves, the physician or provider, they allow nurse practitioners, must be present. And obviously they allow euthanasia. So and again, that's by far the most common method. The physician is there to actually give the medication. But in the United States, the provider is not required to be present. And they're present in this study in Oregon over time, a little bit less than half the time. As I mentioned, there are 9 states now that have passed medical aid in dying laws. Those are outlined here, and Washington, D.C. And that's about 70 million adults who have access to medical aid in dying now in this country. Other concerns that people often bring up, obviously, people's religious and spiritual beliefs, dementia. I want to address just my own feelings about religious and spiritual beliefs. And again, this would be a whole lecture in and of itself. I have one slide. I think in this country, we're a obviously very diverse country with many religions and faiths in this country. And there clearly is not a uniform approach to death. And I don't believe that any religion really believes that dying is always beautiful and peaceful, and that death itself we should take in the actual death we should take comfort in. There are many who believe in life after death, but it doesn't necessarily mean that death itself is beautiful. And many faiths believe there's sanctification and redemption in suffering. I personally don't believe that at least my God, that we need to bear needless and avoidable suffering. And in this country, you cannot define, and we should not define, the religious character of this nation. And we can't impose our own religious beliefs and faith traditions on other people. In fact, we're prohibited from doing that by our Constitution. And I think, a good national theology must be a public theology. Now, we could talk about all that all day, but it's an important part of this discussion. Dementia is a difficult illness. Many of you have probably seen the movie Still Alice with Julianne Moore. A very good movie if you haven't watched it. The difficulty with dementia and medical aid in dying is it is very clear in the law that a patient has to have capacity at the time of their request, and they have to still have capacity at the time they take the medication. So that's difficult. So if you, I've heard a talk about a physician in Canada, and I'm going to briefly review the law in Canada, but again, that becomes you can't wait too long, obviously. If they lose capacity, they're no longer eligible to pursue medical aid in dying. And then the difficulty with dementia patients in prognosis. Sometimes prognosis is very difficult to predict in dementia patients. To say that a dementia patient only has 6 months to live can be difficult. Family conflicts, I think this points out, if we call it the black sheep of the family comes and really raises significant concern. They don't want their mother, their father, their sister or brother to do this. It can raise lots of conflict within the family. I think it raises the importance of advanced directives, of completing advanced directives, and most importantly, when advanced directives are completed and you write a letter about your wishes and your own personal values, that those are carefully reviewed and shared with all family members. And how do I know when I take the medication? As I mentioned, a third of the patients never do take the medication. And I think otherwise, it's a planning process, and some of the deaths are just wonderful, that are carefully planned. Family members are there, loved ones, other loved ones are there in a place they want to be, often, like most commonly at home, music they want to be playing, and they kind of know when they want to take this, and that they've closed other doors and completed the things they've wanted and seen the people they've wanted to see. And why do we care about life expectancy? You often hear arguments about slippery slopes. And one of those might be that, where people in this country will begin to participate and they may not die within, that their prognosis was very clearly not within 6 months. I think in this country that's okay as we start. That's not true in Canada. That I won't go through all this. I think I've talked enough, but they do not put a time frame on prognosis. It has become in Canada, and even this may change in the very near future, but reasonably foreseeable. And this has been upheld in the Supreme Courts of Canada, that it really is the patient is on a trajectory towards a natural death due to their illness. So that 6 months time frame is not part of the law in Canada. There was a patient who went through medical aid and dying in Canada that had severe erosive osteoarthritis. Nobody could say that they were going to die within 6 months, but she was deemed eligible for aid and dying in Canada. And I put other in there for other questions that might come up. I think quickly, things you can do: talk to your people with advanced serious illnesses, talk to their physician, let them know that you actually support medical aid in dying, and ask the physicians if they do, even in Arizona, to start the discussions. Complete advanced directives, and as I mentioned, the importance of reviewing those with your family. Email and call your state Congress people, both the House and Senate. I put the web address on. You can get the members in your districts and their emails. Hold a virtual house party with one of the speakers to help with Arizona end-of-life options. You can go to our website, and there's, as you might think, there's a volunteer to help little thing you can click on. Lots of things that you can do. There's lots of information out there about medical aid in dying on our website. Compassion and Choices is a national organization that's been around a long time. There's lots and lots of information. Much of it is downloadable. Death with Dignity is another website that's been around. And Dwight has provided his number, and there's my phone number and my email. We're both very happy to answer. I probably won't answer, because numbers I don't know, I don't answer because I get so many robocalls, but leave a message and I will call you back.